Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator for NEET PG MDS program. So in this particular session, I'll be just doing a discussion of the NEET MDS recall questions related to general medicine which you have written in the year of 2024. So the first question is as follows. The patient complains of fever, tachycardia, and thyrotoxicosis is being diagnosed, right? So now, what is the correct answer? Decurvain's thyroiditis, goiter, hypothyroidism, hyperthyroidism. Okay. So basically, let me tell you, these are all recall questions, the questions which has been given by the students depending upon their memory immediately after the exam. So the options may be like up and down, or the question frame may be like up and down. So if there is any complete mistake in the question or complete mistake in the options, please ping us in the chat box so that we will be able to correct in the final version. All right. Okay. So now, what is the diagnosis here? Decurvain's thyroiditis, goiter, hypothyroidism, and as well as the hyperthyroidism. We will go one by one. So you take Decurvain's thyroiditis. See, Decurvain's thyroiditis, the another name for this clinical condition is, this is also called as the granulomatous thyroiditis, right? Granulomatous thyroiditis, or it is also called as a giant cell thyroiditis. And this Decurvain's thyroiditis, it is the one which occurs following an upper respiratory tract infection. So you have complete degeneration of the thyroid gland. So like there will be destruction of the thyroid follicular cells. That is the reason why in early stages there will be hyperthyroidism, right? So once there is destruction of the follicular cells by these giant cells or the granulomatous accumulations, the follicular cells, they get destroyed and T3, T4 will be released into the circulation, and that will result in hyper. Then followed by that, once the reserve is finished, then in the later stages, these patients will have the hypothyroidism. So initially hyper, then followed by that the hypothyroidism. Okay. But the clinical picture what has been given is fever and as well as tachycardia. So the presence of fever and tachycardia, they are the features of your hyperthyroidism. All right. And what is the reason for fever in patients with hyperthyroidism? That is because of increase in the basal metabolic rate by the thyroid hormone. Now, what is the reason for tachycardia in patients with hyperthyroidism? Because thyroid hormone, it is a positive chronotropic agent which will increase the heart rate in the individual. So thereby, in hyperthyroidism, the chronotropic effect increases and that will result in tachycardia. Then what about the second option, that is goiter? See, goiter, if there is present in any individual, this goiter, it can be a hyperthyroid, right? Or it can be a euthyroid goiter, right? Or it can be a hypothyroid goiter as well, right? Or hypothyroid as well. So the goiter can be anything, but definitely it need not be hyperthyroidism. So that is the reason why your option 2 is also ruled out, and option 1 is ruled out because initially hyper and later hypo will be there. Then hypothyroidism, you don't have fever and as well as tachycardia. In patients with hypothyroidism, what is that you will have is, you will have bradycardia but not tachycardia. So that is the reason why your option C is also ruled out. So the answer here is the hyperthyroidism, right? Next question. Type 2 respiratory failure, it is characterized by hypoxemia with hypercapnia, hypoxemia without hypercapnia, hypoxemia and hypocapnia, only hypercapnia. Okay, so like we have totally 4 types of respiratory failure. So out of these 4 types of respiratory failure, you take in case of type 1 respiratory failure. In type 1 respiratory failure, these patients, they will have hypoxia, whereas the carbon dioxide levels, either they remain normal or decreased. That will be the picture in case of your type 1 respiratory failure. Whereas you take type 2 respiratory failure. In type 2 respiratory failure, they will have hypoxemia and there will be increase in the carbon dioxide levels. There will be hypercapnia in the individual. So among the options which has been given to you, hypoxemia and hypercapnia is what is suggestive of your type 2 respiratory failure. Whereas you take option B and option C, Hypoxemia without hypercapnia, that can be there in type 1 respiratory failure. And hypoxia with hypocapnia, even that can also be there in your type 1 respiratory failure. And only hypercapnia is not the feature of any of the respiratory failure. So if there is hypercapnia, there will be associated hypoxemia as well, and that is what is suggestive of your type 2 respiratory failure, right? And you take type 1 respiratory failure, that is because of the fluid overload within the alveoli. And type 2 respiratory failure, that is due to alveolar hypoventilation. Type 3 respiratory failure, that is post-operative atelectasis or post-operative respiratory failure, that is type 3. And type 4 respiratory failure is due to cardiogenic shock, and because of which there is decreased perfusion to the respiratory muscles, causing respiratory failure. So these are the 4 types of respiratory failure. But in type 2, you will have hypoxia and as well as the hypercapnia that is being present, right? Next question. Left ventricular end systolic volume is around 70 ml. Left ventricular end diastolic volume is around 120 ml. The heart rate is 70 per minute. What is the cardiac output? So this is like actually the integration of the physiology and as well as medicine, but more of it is like physiology question itself. So now, how do you calculate the cardiac output? What is the formula for the cardiac output? That is the heart rate into the stroke volume. Okay. So now regarding the heart rate, they have mentioned the heart rate, that is 70 per minute is being mentioned. Now you need to know the stroke volume. See, how can you calculate the stroke volume is the end diastolic volume of the left ventricle minus end systolic volume of the left ventricle. That is how you will be able to make out the cardiac output. So 70 multiplied by end diastolic volume is how much? That is around 120 ml minus end systolic volume is 70 ml. So it is like 70 multiplied by 50. So this comes around 3500 ml. So which is equivalent to 3.5 liters per minute is the cardiac output. So the formula, if you know in making out the cardiac output, then you will be able to solve this question. But at the same time, you also need to know how to calculate the stroke volume, which is nothing but end diastolic volume minus the end systolic volume. All right. And exactly in relation to your cardiac output, you have the formula for the blood pressure as well. So the formula for the blood pressure is cardiac output multiplied by the peripheral resistance. Okay, so this is what is the formula for measuring the blood pressure. So if the cardiac output is reduced, definitely the blood pressure also will be reduced. Okay, so the answer in this question is 3.5 liters per minute. And how much is the normal cardiac output in an individual? So normal cardiac output, it is around 5 to 6 liters per minute. Right, 5 to 6 liters per minute is the normal cardiac output. All right, so here it is 3.5 liters per minute, right? It might be because of the age of the individual, that might be a children, or if an adult individual, if the cardiac output is like 3.5 liters per minute, then there is the cardiac abnormality that we need to suspect. All right, next question. Okay, so this was a question related to the emergency medicine. In ACLS protocol, that is Advanced Cardiac Life Support Protocol, along with CPR, which drug should be given for pulseless ventricular tachycardia? The options are digitalis, digoxin, epinephrine, and then the adenosine. Okay, so first of all, let me tell you, this digitalis and digoxin, they have no role in the pulseless ventricular tachycardia at all, right? Where do we give digitalis or digoxin in a cardiac condition is we use that in patients with congestive heart failure with atrial fibrillation. That is one clinical scenario where we use, right? Congestive heart failure with atrial fibrillation. Or we also give them if the patient is having only atrial fibrillation also, to reduce the ventricular rate, because digoxin or digitalis is the one which will increase the refractory period at the level of the AV node. So thereby the conduction of the impulses from atria to the ventricle will be reduced. So it will reduce the ventricular rate, for which we give digoxin. So digoxin we use in congestive heart failure with atrial fibrillation, or only atrial fibrillation also for rate control we give digoxin. And is there any role in pulseless ventricular tachycardia? No role, right? Now coming to your adenosine. Where do we give this adenosine? Adenosine is given in the treatment of PSVT, paroxysmal supraventricular tachycardia. Actually the first line treatment is activation of the vagal maneuvers, right? Or the application of modified Valsalva maneuver. Understood? And if that vagal maneuvers fail, then we give the adenosine. And what will be the dosage of the adenosine? That is 6 milligrams IV bolus that we give as the first dose. And if the patient does not respond to the 6 milligrams, the second dose what we give is 12 milligrams bolus is what we need to give. And with adenosine 12 milligrams also, if the patient does not respond related to your PSVT, then you need to give the non-dihydropyridine calcium channel blockers, that is diltiazem or verapamil, or you can give a beta blocker. Okay. And is this adenosine having any role in pulseless ventricular tachycardia? No. Right. Next. See, actually, then what is the answer here? That is epinephrine is what you need to give. So for a patient who has presented, or who has, like, you have seen the patient with the cardiac arrest. So what could be the reason for the cardiac arrest? You just see this flowchart of the ACLS protocol, right? So a patient had a cardiac arrest. So you need to like ask for the help, right? Shout for the help, and then immediately you need to start the CPR. And at the same time, give oxygen, attach the monitor or the defibrillator. So once you attach the monitor or defibrillator, then you will be able to make out whether it is a shockable rhythm or is it a non-shockable rhythm. If it is a shockable rhythm, what are the shockable rhythms? That is pulseless ventricular tachycardia or ventricular fibrillation. And not shockable rhythm are pulseless electrical activity or asystole. They are non-shockable rhythms. What has been asked for us? About the pulseless ventricular tachycardia, which is a shockable rhythm. So give a shock, and again immediately you need to start the CPR for 2 minutes, and like that you need to give totally 5 cycles. Meanwhile, like, the other person has to obtain the IV access. Okay. Then after giving this particular CPR, again you just check the monitor, like the cardiac monitor, whether the rhythm has been reverted or not. If the rhythm did not revert, then if it is a shockable rhythm, just give a shock once again. After giving shock, then again continue the CPR for 2 minutes for 5 cycles. Now, whenever you are continuing the CPR for 2 minutes for 5 cycles, this is the point when you can consider giving epinephrine every 3 to 5 minutes. Right? Epinephrine every 3 to 5 minutes, and consider the advanced airway and as well as capnography. Advanced airway in the sense, like, you need to intubate the patient and you also need to estimate the levels of the carbon dioxide in the body. And after doing all this, again you check whether it is a shockable rhythm or not a shockable rhythm. For suppose if it is still a shockable rhythm, then give one more shock. Then continue the CPR for 2 minutes for 5 cycles. And this is the point when, so initially you are giving epinephrine. Later on, the antiarrhythmic drug, that is amiodarone or lidocaine, then you also need to treat the underlying cause. Right. So this is like the approach for the pulseless ventricular tachycardia. So in pulseless ventricular tachycardia, the drug that you will be giving along with CPR will be epinephrine. Some of the students said, like, sir, one more option was amiodarone also. Right. If amiodarone is also given, the amiodarone is also a correct answer. But what would be the best in between opting the epinephrine and as well as amiodarone is the epinephrine, because you are giving epinephrine in the second cycle of the CPR itself. Okay, so epinephrine would be the best if amiodarone was also given as an option, right? If amiodarone was not given, definitely it is only the epinephrine which is the answer. So this is like one of the very important questions related to the emergency medicine. Emergency medicine is one particular area definitely you need to revise and you need to read just before going to your exams. Okay, next question. A patient with symptoms suggestive of the acute cholecystitis, right, where he had pain in the right hypochondrium, and some students said, like, sir, Murphy sign is also positive. That is what they have said, like, with complaints of loose stools. Now, what could be the reason for the malabsorption of the fat in patients with acute cholecystitis? The options are lipase deficiency, chymotrypsin deficiency, amylase deficiency, and decrease in the bile salts. So now, what is the clinical presentation? The clinical presentation is suggestive of acute cholecystitis, right, where there is inflammation of the gallbladder and there will be also inflammation of the cystic duct. So because of which the bile which is there within the gallbladder will not empty, right, will not empty into the second part of the duodenum. Right, will not empty into the second part of the duodenum. So that means what? Your bile acids and bile salts which have to be released into the second part of the duodenum, they don't get released. So thereby, once there is a decrease in your bile salts, what happens? The emulsification of the fat does not occur. Okay. So once the bile salts are not there, then the emulsification of the fat does not occur. Right? Once the emulsification of the fat does not occur, then the individual will have like malabsorption of the fat. Now, what about the other options? The other options, if you see, lipase deficiency, chymotrypsin deficiency, and amylase deficiency, these are observed in case of the pancreatic disorders. Right? In pancreatitis or pancreatic abnormality, you will have this lipase, chymotrypsin, and as well as amylase deficiency. Because of lipase deficiency, there can be malabsorption of the fat. Chymotrypsin, there can be malabsorption of the proteins. Amylase deficiency, there can be malabsorption of the carbohydrates. But please remember, because of the acute cholecystitis, like amylase, lipase, chymotrypsin deficiency will not be there. So because of this acute cholecystitis, there can be decrease in the bile salts, and that will cause the malabsorption of the fat. So the answer here is D, that is the fourth option. Right? Next question. Okay. So metabolic acidosis with normal anion gap is due to hyperkalemia, diabetic ketoacidosis, diarrhea, and then the uremia. Okay. So please remember normal anion gap. How much is this normal anion gap? That is around 8 to 12 milliequivalents per liter is the normal anion gap. So among the options which has been given to you, which is that clinical condition where you have a normal anion gap and then metabolic acidosis? The answer here will be the diarrhea. So in case of diarrhea, you will have normal anion gap metabolic acidosis. Whereas in diabetic ketoacidosis and as well as in uremia, in both of these clinical conditions, you will have what is called the HAGMA. So what do you understand by this word HAGMA? That is high anion gap metabolic acidosis. Now let me just quickly recap all the conditions where you have this NAGMA. So NAGMA is what? Normal anion gap metabolic acidosis. So normal anion gap metabolic acidosis, you can just remember this mnemonic as a used car, right? U stands for uretral diversion, right? Like uretrosigmoidostomy, all that. Second, saline infusion, that is S. E stands for exogenous acid administration. D stands for diarrhea, what is given in our options. Then C stands for carbonic anhydrase inhibitor. And A stands for adrenal insufficiency. R stands for renal tubular acidosis. So these are the clinical conditions where you will have the NAGMA, right? Then followed by that, what are the conditions where you have the HAGMA? That is high anion gap metabolic acidosis. High anion gap metabolic acidosis, please remember this mnemonic as mud piles. What is this mud piles? M stands for methanol ingestion or methanol toxicity. U stands for uremia. D stands for diabetic ketoacidosis. Then P is paraldehyde or fenformin toxicity. I is your isoniazid or iron toxicity. L is lactic acidosis. E is ethylene glycol or ethanol intoxication. S stands for the salicylates. So these are the conditions where you will have the elevated anion gap. So like what is the option given to us? Like diarrhea, where you will have a normal anion gap. So this was a question on ABG. ABG is one important topic. Definitely the question will appear every year. Either one question or two questions. But this time you have two questions from the ABG. So even the next question is also on the ABG. Let me solve this. Right. So partial pressure of the carbon dioxide of the individual is 90 millimeters of mercury and partial pressure of oxygen is 25. pH is 7.12 and the individual is alcoholic with breathlessness since 2 days. What is the reason? Right. So, okay. If you take the pH, it is 7.12. So what exactly is this? It's acidic pH, right? Then you take PCO2. So PCO2 is 90 millimeters of mercury. So if you take pH, it is reduced and PCO2, it is increased. So like what is the rule? The rule is that if pH and PCO2, if they change in same direction, the primary acid-base abnormality will be metabolic. But here the pH and PCO2, they have changed in opposite direction. So that is the reason why the primary acid-base abnormality will be respiratory. Right? The primary acid-base abnormality will be respiratory. So respiratory what? The pH is like 7.12. So this is the respiratory acidosis. Right? So this is respiratory acidosis. Right? Now, which among the option will cause the respiratory acidosis with hypoxemia, and that too in an alcoholic individual? Okay, let me just make out this. So you take, because your respiratory acidosis means what type of respiratory failure does this comes in? It will come in your type 2 respiratory failure. All right, and you take all these options: COPD, asthma, ARDS. All these will cause type 1 respiratory failure, but all of these clinical conditions in later stages or in severe stages will cause your type 2 respiratory failure. But among the options given, with the clinical history given, what is that we can suspect to be the cause for type 2 respiratory failure? With the clinical scenario given, the alcoholic individual. See, please remember, these alcoholics, they are at increased risk of the aspiration. Right? So they can be increased risk of the aspiration of the gastric contents. Right? So because of the aspiration of the gastric contents, these patients, they are at increased risk of development of the acute respiratory distress syndrome. Okay, because of the increased aspiration of the gastric contents, there can be development of the ARDS. So in ARDS, it is actually type 1 respiratory failure, and this ARDS also, according to the Berlin's criteria, based on the PaO2 by FiO2, right? Based on PaO2 by FiO2, we classify these patients with ARDS into like mild, then moderate, then severe ARDS, right? So in mild ARDS, the PaO2 by FiO2 will be around 200 to 300, whereas in moderate, the PaO2 by FiO2 will be around 100 to 200, whereas in severe, the PaO2 by FiO2 will be less than 100. Understood? So in case of mild to moderate, it will be your type 1 respiratory failure where the individual has the hypoxemia. Whereas in severe form of respiratory failure, it is your type 2 respiratory failure where the individual will have the hypercapnia. Right? Where the individual will have the hypercapnia. So the answer here is ARDS. The answer is ARDS. How is that we are able to make out that it is an ARDS? Because the individual is alcoholic. Right? Alcoholics, because of the aspiration of the gastric contents, they can develop the ARDS. Right? Next question. Okay, so this was the question on the nephrology diagnostic criteria for the acute kidney injury. So the question was basically given based on the definition of acute kidney injury: increase in blood urea nitrogen, increase in serum creatinine more than 0.3 milligrams per deciliter in 48 hours, decrease in urine output less than 1 ml per kg per hour, decrease in the GFR. Okay, now, so you take acute kidney injury. What is the definition of acute kidney injury? Definition of acute kidney injury is based on increase in serum creatinine. And how much should be that increase in serum creatinine? That will be more than 0.3 milligrams per deciliter within 48 hours. Right? Within 48 hours. Okay. And the other parameter or the other definition of your acute kidney injury is there will be definitely decrease in the urine output. But how much will be the decrease in the urine output? Decrease in urine output will be less than 0.5 ml per kg per hour for nearly around 6 hours. Okay, this should be decrease in urine output to consider it as the acute kidney injury. So diagnostic criteria for acute kidney injury is what now? That is increase in serum creatinine more than 0.3 milligrams per deciliter within 48 hours. What about increase in blood urea nitrogen? Yes, it can increase, but proper quantification is not given in the option. So first option ruled out. Right? Decrease in urine output. How much it should be? Less than 0.5 ml per kg per hour for nearly around 6 hours. So this is ruled out. Okay. And decrease in GFR. This is the criteria mainly for the chronic kidney disease, but not for the acute kidney injury. Right? Next question. A patient comes with chest pain. On X-ray, left-sided hemithorax opacification is seen. The pleural tap is done. Which of the following is an indication for chest tube thoracostomy in this case? Pleural fluid glucose more than 80 milligrams per deciliter, presence of frank pus, serum albumin level more than 0.6 milligrams per deciliter, the pleural pH more than 7.2. See, actually, what is the treatment for pleural effusion? That is pleurisynthesis, right? But there are certain clinical conditions where you need to place a tube thoracostomy. Very, very important clinical condition is the presence of the frank pus, right? The presence of frank pus, what do we call it as? This we call it as empyema. So when there is empyema, that cannot be aspirated with the help of the needle. So definitely you need to place the chest tube. Then what about the glucose? How much should be the glucose? Please remember, if the pleural fluid glucose, if it is less than 60 milligrams per deciliter, that is the point when we place this chest tube insertion, right? Then no role of much of the albumin in placing the chest tube. Then the pleural fluid pH, right? And how much should be the pleural fluid pH? It is not more than 7.2. It should be less than 7.20. That is the point when you need to place a chest tube insertion, right? And the presence of the gross pus. So these are the indications for chest tube insertion and draining out the fluid in patients with the pleural effusion. So the answer is the frank pus, right? Next question. In fact, this is the last question if I'm not wrong. So which of these investigations will assess the upper airway obstruction during sleep and help in deciding whether the patient will be benefited from the continuous positive airway pressure or the airway devices? The options are bronchoscope, pharyngometry, cinefluoroscopy, polysomnography. So what is the clinical scenario given to you here? So the individual is like getting up from the sleep. Okay. So will assess the upper airway obstruction during the sleep, and that is one point, and benefited from the CPAP. So intermittent arousal during the sleep and requirement of the CPAP, it is very much important in patients with the OSA, that is obstructive sleep apnea. And in patients with obstructive sleep apnea, what is the best way by which you can diagnose? You can diagnose it by the polysomnography, right? And based on this, you will be able to assess even the severity of the obstructive sleep apnea as well. So you take in case of mild OSA. In mild OSA, the number of AHI will be 5 to 14 apnea-hypopnea index events per hour. Moderate OSA, it is around 15 to 29 AHI events per hour. And severe, it is more than 30 events per hour. So that is how you will be able to assess the severity of the OSA. So the best method is what? For diagnosing the OSA or the investigation of choice, that is polysomnography. So these are the these are the questions which have come up in the NEET PG MDS exam in 2024, right? So those who are just about to prepare for the upcoming NEET PG exam MDS or INICET MDS, let me just tell you, the eGurukul have come up with the Advan Plus 2 version. Okay, that is V.2 version, right? This is like a very important update regarding the NEET MDS or INICET MDS, right? All the videos are completely new and they are very good. And the pre-recorded videos, almost 600 hours of the pre-recorded videos will be available in the new version. And you also have extensive question bank of nearly around 20,000 questions plus, and that too completely are exam oriented. And in this new version, there are many competitive test series which are very, very useful for the NEET MDS exam. And you also have the option of the clinical world, which are having like 40 plus hours of the clinical videos. And you also will be given the hard copy notes, like which is crafted and curated by all the educators who have done the recording. And not only that, you also have the revision videos along with the main videos as well. And very important is Dr. Himani will be taking even the daily mentorship, right? These are like special sessions by Dr. Himani Joshi to help you stay motivated and as well as on the track, right? So I wish you all the best for the learners and the students who are appearing for the next NEET MDS exam and as well as the INICET MDS exam. Thank you very much and I wish you all the best. And for any doubts, right, you can just contact us. Definitely we are there for you to help you in your journey of getting through the seat of NEET MDS or INICET MDS. Thank you very much. All the best.